My assigned topic was to talk about the current role of immunotherapy in the treatment of patients with cancer. These are my conflicts of interest or disclosures. I consult for a lot of companies, and a lot of people might think that's a problem, but this is how companies make treatments and do studies that are useful to patients. They're talking to doctors who take care of patients every day. So a lot of you might remember that in 1971, then President Nixon declared war on cancer. But in truth, the war on cancer has been going on throughout history. And this is a grave dug up of a medieval Saxon man with a large tumor in his femur, showing that cancer is not something just of the 20th or 21st century. But this war on cancer is not fought between the National Cancer Institute and tumors. It's not fought between medical oncologists or cancer centers and tumors. It's not even fought between patients and their families and tumors. The principal combatants in the war on cancer are actually the malignant cell population and the host immune system. And so if you think about that, it gives you a sense of why we're trying to use immune therapy. The host immune system is really the dominant active enemy faced by any developing cancer. And all successful cancers, as Dr. Gully was talking about, must solve the challenges of overcoming defenses erected by the host immune system. So they're there, and the cancers have to figure out how to get around them. And they do this in many different ways. They can overwhelm the immune system by just growing faster than the immune system can kill them. And there are some cancers, Burkitt's lymphoma is an example, that can actually do this. They can hide from the immune system by having lack of presentation of their new proteins on their surface. By either losing the MHC molecules that are involved in those presentations or by some other mechanism. They can subvert the immune system by making immunosuppressive substances like chemokines or cytokines, and they can shield themselves from the immune system by having factors that exclude the immune cells from getting into the tumor, either by erecting physical barriers or by having substances that exclude or prevent the immune cells from getting into the tumor. Or as has become very important, and Dr. Gully alluded to, they can defend by deactivating the immune cells once they get into the tumor microenvironment. And tumors use all those things, but as we're understanding, this last one is critically important. And so when we talk about cancer immune therapy, we're talking about treatment of the disease by inducing, enhancing, or suppressing an immune response. And then maybe a better way of saying this is what my colleague Jed Walchuk said. It is, instead of just directly treating the cancer, it's treating the immune system so it can treat the cancer. And what we've learned from trying to do this recently effectively is that immune therapy can cure patients with cancers. So how does that happen? Well, all tumors have some abnormal genes in their DNA because of mutations either from smoking damage or sun damage if it's melanoma or other environmental factors. That's what causes them to be cancers. There are driver mutations that may push the cancer predominantly, and there are a lot of passenger mutations that are just there and don't have any function, but they're just there because there's no reason to get rid of them. And this is a picture of all the mutational load in various different cancers with melanoma, lung cancer, bladder cancer, some of the most immune responsive tumors being here with the highest mutational load. And these mutated Mutations cause mutated proteins which represent potential antigens or targets for immune recognition or destruction. And how does that happen? Well, Dr. Gully spent a lot of time discussing this, so I won't go into a lot of detail, but this is the simplistic view of how the immune system interacts with a tumor. These tumors have mutations which lead to abnormal proteins which are secreted when a cancer cell dies, and their cancer cells are dying all the time, and these are picked up by these antigen-presenting cells or dendritic cells, processed into peptides and presented on the surface of these dendritic cells, which then travel to the lymph node, and in the lymph node they recognize T cells, or T cells recognize these proteins and through their T cell receptor and a co-stimulatory molecule that's very important on the T cell that binds to a co-stimulatory molecule on the antigen-presenting cell. And that causes these T cells to become activated. They leave the lymph node, go out to try to find their target. When they see their target on the tumor, they start to clonally expand with the use of excretion of IL-2 or T cell growth factor, and they make perforin and granzyme, which attacks the tumors, kill the tumor cells, releases more antigen, and broadens and advances the immune response. And so we knew this for a long time, that this was happening, and therefore one of the ways in which we thought was best to improve the immune response was to work here and expand these T cells in the tumor microenvironment. And we did that initial studies 20, 30 years ago with a substance called IL-2, which is T cell growth factor. And IL-2 could cause T cells to grow and expand. And in the early studies, when this was given at high doses, we could see responses in about 15 to 20% of patients with melanoma and kidney cancer. And about half of those responses lasted and were complete. And if those responses, as were shown here, these are response duration curves, lasted 2 to 3 years, then very few, if any, patients would ever recur after that. So this is response duration curves that are flat after 2 to 3 years and going out 10 years, and one could add another 10 years on top of that with longer follow-up since this publication. So the trouble with IL-2 was that it was toxic, it was complex, and had to be delivered as an inpatient regimen. And therefore its use remained limited to selected patients treated at a few experienced centers. And we spent a lot of time trying to develop more tolerable regimens with lower doses of IL-2 combined with other agents, and those were largely unsuccessful. Then we tried to identify the patients who were most likely to respond to high-dose IL-2 so we could restrict the therapy to those who were most likely going to benefit. And we had some success there, but we were not able to get the response rates much beyond 30%. And so we sort of hit a wall with this approach to stimulating the immune system, and we needed better ideas. But it was still, the experience with IL-2 for those of us who were involved in it was transformative, because it was proof of principle that if you could activate T cells, activate the immune system, you could eliminate cancer and you could cure at least a subset of patients. And it was that observation that kept a lot of us working in the field through the dark ages of immunotherapy while everyone was talking about every other type of treatment, and trying to come up with what the problems were and what was preventing the immune system from being activated in more tumors and more patients. So what we learned in our studies of who was responding, and Dr. Gully talked about this, was there were two types of tumors. There was a non-inflamed tumor, which had low inflammation and low chemokine expression, which meant that there were very few T cells that made it into the tumor. And inside the tumor microenvironment, there wasn't a lot of oxygen, and there was expression of a lot of factors such as vascular endothelial growth factor, macrophages, and fibroblasts that made it a very inhospitable environment for the immune system to work, even if the immune cells could get there. And there was another type of tumor that was an inflamed tumor that had chemokines being made, high inflammatory signals. The T cells would come in to the tumor, but nevertheless, there were a lot of other factors that Dr. Ghali talked about, either inhibitory receptors, suppressive cells, or suppressive enzymes that prevented those T cells from doing their job, killing the tumor once they got into the tumor microenvironment. And paradoxically, it was these cells, these tumors that had these T cells in it, but all of these immunoregulatory factors that tended to be the ones that were most likely to respond to immune therapy when we did see responses, be it IL-2 or sometimes with vaccines. And so based on this, the doctors at the National Cancer Institute thought that if these T cells are here and they can potentially recognize the cancer, but they're being inhibited by the tumor microenvironment, maybe we should take these T cells out and grow them up in vitro, in a test tube, to large numbers, identify the ones that most recognize the tumor, get rid of all these immunosuppressive factors by giving high doses of chemotherapy, and then give these new immune system back that recognizes the tumor. So that's what's called TIL therapy. And this was work that was done at the National Cancer Institute by Steve Rosenberg and a number of other investigators. And when they did this, they found that you could take patients whose disease didn't respond to high-dose IL-2 and see complete responses with this approach, and that these responses tended to be durable, similar to the responses with high-dose IL-2. You can see these are survival curves, and they're very flat after the 3-year time point. So we wondered if those T cells recognize the tumor and they're there, is there some way we can activate those T cells in the tumor microenvironment without having to go through the trouble of taking them out, expanding them in the test tube, and giving high doses of chemotherapy to eliminate the patient's existing immune system and immunoregulatory factors. So that's where the key observation of these immune checkpoints comes in. Because what we learned is both at the priming phase, where the dendritic cells are presenting antigens to the immune system, and at the effector phase, there are inhibitors or brakes on the immune system to keep it from going haywire. At the priming phase, one of these is CTLA-4 binding to B7, the priming phase, and at the effector phase, it's PD-L1 binding to PD-1 on the T cells. And so we could give antibodies to block those interactions, and one of those antibodies is ipilimumab that you've heard about, another one, tremelimumab, that binds to CTLA-4 and prevents it from binding to B7, which keeps the T cells active at the priming phase and allows them to go find the tumor in expanded numbers. And so when we gave antibodies, CTLA-4, to patients with melanoma, as Dr. Ghali showed you, we could see responses in about 10 to 20% of patients. And just like the responses to IL-2 and TIL, if the patient was alive at 3 years, they were likely cured. And that represented now 22% of all patients. But when you activated the immune system at the antigen-presenting phase, you were activating the immune system not just against the tumor, but a lot of other host substances. So this therapy was associated with a lot of immune-related toxicities against the colon, the skin, pituitary gland, and the liver. And we wanted to be able to activate the immune system directly in the tumor microenvironment because it could be more selective in doing that. So that's where these antibodies that bind either PD-1 or PD-L1 came in. And because of the power of that particular concept, a lot of companies saw this as the key to effective immune therapy and developed these antibodies, and there are now 6 or 7 of these antibodies that have been in clinical testing against a variety of different tumors, and they have had numbers, now they have generic names, and some of them are starting to have brand names. And I'm going to talk to you about the results of those studies with the PD-1 blockers, which is really the principal key that has revolutionized the way we're going to treat cancer going forward. So the first agent studied was nivolumab, and it was a phase 1 study in a variety of different cancers. And we saw responses in melanoma and kidney cancer, similar to what we had seen with IL-2 in about a third of patients. But what was really novel was that about 17% of patients with lung cancer, a disease which we never imagined would be responsive to immune therapy, about 17 to 20% of patients were exhibiting responses. And the responses that we were seeing here shown in melanoma were very durable. These are swimmer's plots, and each line here is a patient. Each arrow is an ongoing response. This is melanoma patients treated with an anti-PD-1 called pembrolizumab, and 88% of the responses were ongoing at the time that this data was presented, and about 40%, 30 to 40% of patients had responses. So this data led to the FDA approval of pembrolizumab just a little over a year ago for the treatment of patients with advanced melanoma, the first anti-PD-1 to be approved. The second anti-PD-1 to be approved was nivolumab, and this was in study in patients who had had prior ipilimumab and their disease hadn't responded. And it was a randomized study where patients in that setting were either randomized, either received nivolumab, anti-PD-1, or standard chemotherapy. And what was seen was that there was a much higher response rate, 32% for nivolumab versus 10% for chemotherapy, and there was longer duration of response. But 36 of 38 patients who were responding were continuing to respond as at the time when this data was presented. And this data led to the FDA approval of nivolumab in December of 2014 for the treatment of refractory lung cancer. And so what's happened is these agents have been tried in a lot of cancers, and right now, this is the list of cancers that these anti-PD-1s have activity in, 20 different cancers. There's never been a therapy in cancer that can be active in so many different cancers. And the ones in red here are the ones where there are already phase 3 trials that are going to lead to FDA approval. There have been 8 phase 3 trials done with these agents, and all 8 have been positive. Usually when we do phase 3 trials in oncology, maybe 1 in 5 is positive. And that's a justification for how expensive these therapies are. But with these immune therapies, when you're looking at overall survival as the endpoint, every trial so far has been positive compared to standard treatments. So I'm going to talk about a few of these examples here, including a couple that really highlight some important principles. But before I say that, there's... No. Matter of fact, they're not dose dependent. These are probably active over a 2 log dose. And I'll get to that in a second. But just to point out, there's some tumors which have yet to actually have a high response to anti-PD-1, and that's a subject of research to try to figure out what's different about these tumors, because they do have antigens, but why aren't the immune system recognizing them? And some of these are the most common cancers. So what is some of the data? This is data looking at nivolumab in 2 studies, patients who'd progressed with chemotherapy for either squamous cell or non-squamous cell lung cancer, comparing nivolumab versus Taxol chemotherapy. And in both studies, the nivolumab had longer survival than the standard chemotherapy, significantly longer survival. And you can see the start of tail on these curves, meaning that they're going to be long-term survivors for the first time ever with immune therapy in non-small cell lung cancer. So this data led to the approval of nivolumab in March of 2015 in second-line squamous cell lung cancer, and very recently, nivolumab was approved for non-squamous cell, non-small cell lung cancer as second-line therapy. Pembrolizumab, the other anti-PD-1 antibody, was studied in lung cancer, And it was studied by looking at the patients with a PD-L1 biomarker in their tumor. And in that group of patients, there was a 41% response rate, and a lot of those responses were durable. And that data led to the recent approval of pembrolizumab for the treatment of patients with non-small cell lung cancer. And this is the first approval with a companion biomarker, meaning that there's a test for who is going to get this drug by looking at PD-L1 expression in the tumor, which seemed to be important with this particular antibody. This is data recently presented in Vienna for kidney cancer, showing that nivolumab produces rapid and durable survival benefit compared to a standard second-line therapy in patients with kidney cancer, everolimus. And this result will, in the very near future, lead to the approval of nivolumab for the treatment of patients with VEGF receptor inhibitor refractory kidney cancer. This is data in bladder cancer. These are spider plots showing the amount of tumor shrinkage in patients with refractory bladder cancer. Bladder cancer is a disease where we have not had a new therapy developed in 20 years. And these were patients for which there was no treatment, and somewhere in the range of 30 to 40% were having tumor shrinkage. Each line going down represents tumor shrinkage with a PD-L1 antibody, atezolizumab. And this data in a phase 2 study led to FDA, or phase 1 study led to FDA breakthrough designation for the treatment use of PD-L1 antibody in bladder cancer. And just at the meeting in Vienna, there was updated data from a phase 2 study showing that somewhere around a third of patients with bladder cancer who have high PD-L1 expression will have responses, and that these responses can be very durable. Overall, about 43% of patients who had some degree of tumor shrinkage with PD-1, PD-L1 blockade. And that's likely good, because of that breakthrough designation, going to lead to the approval of atezolizumab in bladder cancer in the very near future. And this is squamous cell cancer of the head and neck, a disease that's a very awful disease for patients to have, and patients who've progressed on chemotherapy have a short survival. And this is data suggesting that somewhere around 56% of patients had tumor shrinkage with these anti-PD-1, PD-L1 antibodies. And so going back to this mutation diagram, turns out the tumors that are responding the most are those tumors that are on the right-hand side, those with the most mutations, suggesting that these mutations form the antigens that the immune system recognizes. And in contrast to targeted therapy, where you're just blocking one driver mutation in a tumor, when you're activating the immune system, you're activating T cells against multiple mutations within the tumor. So the tumor can't escape by getting rid of one of these proteins. It's, instead of being shot with a rifle, it's being machine gunned, and there's no way to escape, and that's why you can get complete responses. And so how do we know that's the case? This was data work that was done at Johns Hopkins looking at a type of colon cancer, which is part of something called Lynch syndrome, which has deficiency in DNA repair, leading to 10 to 100 times the number of mutations in these tumors compared to garden variety colon cancer. And there are other tumors that have this mixed-match repair deficiency. And when you look at PD-1 blockade in these tumors, those that have these higher mutations had 60% response rates, while there were no responses in normal colon cancer, indicating the importance of having these multiple mutations. But here's the data that I really like. So this is data in Hodgkin's disease. Now, Hodgkin's disease is called a lymphoma because there are a lot of immune cells there, a lot of lymphocytes there. But in truth, those lymphocytes are not malignant cells. And I'll tell you why they're there in a second. But Hodgkin's disease is the quintessential disease in which combination chemotherapy was developed because it could cure patients. And so this is what built combination chemotherapy in the 1970s and 80s. And so if you took patients who had received combination chemotherapy and high-dose chemotherapy with bone marrow transplants, 23 patients and gave them nivolumab. They had received these therapies and their disease still grew, and give them nivolumab. 20 out of 23 had responses, and these responses were very durable, with 86% of those lasting over 2 years. So this is a disease that standard therapy, chemotherapy, one of the real triumphs for chemotherapy that is going to be much better treated with immune therapy in the future. So why is that? Because these tumors, as it turns out, this is what this looks like, all these immune cells, but the actual tumor cell is hard to find in the Hodgkin's disease. It's something called a Reed-Sternberg cell. And this Reed-Sternberg cell has a genetic mutation that puts PD-L1 or PD-L2 on its surface. And that, if you can imagine, what that means is this tumor cell is preventing itself from attack by all these immune cells by expression of this one defense molecule, highlighting the power of that defense molecule. And if you just block the ability of this molecule to actually fend off these immune cells, you can see it'll be pretty easy to eliminate that cancer cell. So I predict in 2 years, immune therapy will be the only treatment given for Hodgkin's disease. So the other great thing about these anti-PD-1 agents is they're very well tolerated. If you talk to patients getting anti-PD-1 and you say, what are your side effects, they have to think about it. It's not immediately obvious to them. But the type of side effects we see in about 5 to 15% of patients are fatigue, rash, sometimes some diarrhea, sometimes some liver abnormalities, sometimes some thyroid abnormalities. But the most significant side effects, grade 3 or 4 toxicities that cause us to modify therapy, happen in less than 5% of patients. So what are we doing with single-agent anti-PD-1? We're trying to figure out when can we stop treatment. Typically, the therapies might go on for years and years, but we think that's probably overkill because the immune system is being activated, and we might be able to stop treatment sooner in patients. And so we're working on examining patients, doing PET scans after a year or so, and coming up with rules for potentially stopping, which is easier now that drugs are approved and we can restart if the tumor comes back. We're looking at moving these into the adjuvant setting and the high-risk setting to prevent metastatic disease, and those protocols have started in melanoma and will happen in other cancers very soon. And we're looking at combinations with other immune therapies, with radiation, with targeted therapies, and we're looking at trying to identify who are the patients who can get away with single-agent immune therapy through biomarker research. But on the combination side, we wanted to look at combining ipilimumab with nivolumab, anti-PD-1 with an anti-CTLA-4 as a way to see whether or not we can improve the results. And Dr. Schnall, who'll speak to you later on, led a lot of this research. We were fortunate enough to participate in the early studies. And as if you can see, the combination produces rapid and deep tumor responses in the majority of patients. And the number of patients responding is greater than the sum of the number of patients who respond to the single agents. And when you give this combination therapy, you see responses in about 60% of patients, much more so than with ipilimumab alone. And this data led to the